Okay. Uh, Today we will begin with the topic Polycystic Ovarian Syndrome. So, the principal features of PCOS will be your ovulatory dysfunction, androgen axis, and there will be polycystic morphology of the ovary on ultrasound. So, it also has complex features like metabolic syndrome, hypothalamic interactions, pituitary ovarian and adrenal interactions. The most common endocrine or metabolic disorder in female is your PCOS. So, coming to the incidence of the PCOS, according to the National Institute of Health, there is 6% of incidence in female. According to Rotterdam, it is 10%. According to androgen axis PCOS, it is 10%. Okay. So, who are the people who are at risk for PCOS? Mostly, it will be a woman who is obese, which leads to insulin resistance, type 1 or type 2 diabetes, or history of premature adrenarche, and a family history, primary relative with PCOS, any ethnicity belonging to Mexican, Australian, or South Asian, mostly Chinese, and certain drugs like anti-seizure, valproate, which leads to androgen biosynthesis. These are the high risk women. Now, well, let's see the pathogenesis of PCOS. So, the current perspective, we have a genetic predisposition as well. So, PCOS as a genetic trait in monozygotic twins, we can see in 70%, dizygotic 38%, or PCOS in mother or sister, there is a chance of 20 to 40% in a daughter. Okay, the genes involved in PCOS, mostly they are located on chromosome 2 or 9 and certain DAND1A or THADA gene. What do? They basically regulating the gonadotrophin secretion, insulin secretion, ovarian follicular genesis, and androgen biosynthesis or action. See this chromosome 2 or 9, which has a action on LH. Okay, and DAND1A leads to hyperandrogenemia and increased insulin after glucose overload. TADA gene increases the LH and testosterone level. Now we'll see what is the action of LH and all later. Okay. Now the second theory is gonadotrophin secretion and action abnormality. So there will be altered LH action which is involved in the pathogenesis of PCOS. Whenever there is a increased serum luteinizing hormone throughout the cycle, or high LH frequency or amplitude, that leads to overexpression of LH receptor on theca cell. Why are we saying that LH will lead to PCOS? Because LH acts mainly on your theca cells. Theca cell is the one which produces the androgens in the body, in the ovary. So these excessive androgen will lead to impaired follicular development, and that leads to an ovulation, because of which there is no production of progesterone. When there is no ovulation happening, no corpus luteum, no progesterone production, and that leads to inhibition of gonadotrophin releasing hormone. So ILH level is not mandatory, but its presence is important for the pathogenesis of PCOS. So many small follicles, because as we have told, there is increased androgen which leads to impaired follicular development. So there is follicular arrest. So these small follicles produces AMH, again which inhibits the action of FSH. There is again abnormal follicular development. So what happens in PCOS? There is increased LH, increased AMH, decreased FSH. Okay, the same thing I have written here. See, LH acts on the theca cell, which increases the androgen production, that leads to follicular growth arrest. There is no dominant follicle, no ovulation. decreased progesterone, which has a negative feedback on GnRH, and that again, decreased negative feedback that leads to more of LH. It's like a vicious cycle. Then the third pathogenesis is dysfunction in ovarian folliculogenesis. As we have already told, there is no dominant follicle. There will be insufficient FSH, which is because of AMH. And again, these Theta cells are more sensitive to LH. Okay. Next, fourth theory is insulin secretion. So up to 70% of female with PCOS have insulin resistant. This could be because of the GLUT4 defect. Whenever there is a insulin resistance, there is hyperinsulinemia. This hyperinsulinemia causes decreased sex hormone binding globulin synthesis, and that leads to increased free androgens. This hyperinsulinemia also acts on the theca cells, which leads to increased production of androgens. Okay. Then obesity, up to 50% of female with PCOS will be obese, and this obesity will lead to insulin resistance, and then again this insulin resistance increases the free androgens in the body. Androgen excess, this could be from ovary, primary or secondary from the adrenal glands. And environmental factors, what are the factors which leads to PCOS? That is your metabolic syndrome, dyslipidemia, hypertension, hypoglycemia, and obesity. So what are the things we are supposed to know in pathogenesis? One is your genetic predisposition. Second thing is a gonadotrophin secretion and action abnormality. Third thing is increased androgens, could be from your ovary or from the adrenals, or hyperinsulinemia and obesity, dysfunction of the ovarian folliculogenesis. Then environmental factors. So there is something called as two hit hypothesis. The first hit leads to genetic predisposition. Second hit is because of the environmental factors. Okay. Same thing I've just explained in the diagram. See, these theca cells which are hyper responsive to your LH. These are the theca cells. So there will be arrest of follicular growth. Then there will be decreased negative feedback on the GnRH. There's no follicle, no negative feedback on the GnRH. Again, there is increased LH and FSH as well, but then the action of the FSH is reduced because of your anti-Mullerian hormone. Okay, so the LH again acts on theca cell, again they increase androgens. And the second thing is obesity. Obesity leads to insulin resistance in 70%. That again leads to your increased androgen. There is a lean PCOS as well, where the insulin resistance will not play a major role. Okay, now let's come to the estrogen level. This estrogen level can be normal or increased in obese PCOS. Because of what? In obese PCOS, the at the periphery, these androgens gets converted to estrogens in the adipose tissues. So that again leads to increased estrogen in the body. Okay, in lean PCOS, estrogen will be normal. So which estrogen is produced in the adipose tissue? E1. That is why in obese PCOS, E1 will be more than E2. The ratio of E2 to E1 will be reversed. And FSH level will be normal. There is a normal feedback inhibition by estrogen. There is no dominant follicle, local inhibition of FSH by AMH. Now LH is raised, FSH is normal, the ratio will be raised. Okay, so this is about the pathogenesis of PCOS. Now let's come to the clinical manifestation. How do they present to us? Most of them will present to us with menstrual irregularity. Either they present with amenorrhea or oligomenorrhea with anovulation. So They can have regular during the regular cyclical bleeding. The bleeding is because of progesterone withdrawal. But in PCOS, there is no progesterone, no withdrawal. They can have oligo or amenorrhea. So, but the thing is, we know estrogen is present in the body. Estrogen will be continuously acting on the endometrium, but there is no progesterone acting on the endometrium, because of which estrogen leads to hyperplasia of the endometrium. At one point, there will be breakthrough bleeding, which will be heavy bleeding. So, that is a long cycle followed by heavy bleeding, is what is the clinical picture. And amenorrhea will be seen in lean or thin because they have normal estrogen, and there is no heavy bleeding because estrogen is not acting continuously. It is not leading to hyperplasia of the endometrium. No breakthrough bleeding. That is why they will have a normal flow. Okay. Next, there will be features of hyperandrogenism. So the features will be like your hirsutism. The hirsutism is the growth of thick coarse hair in male pattern distribution. Okay, and there will be acne, male pattern baldness. These are the clinical features. On biochemical parameters, there will be increased testosterone level. In normally the levels will be up to 60 nanogram per deciliter, but in PCOS it reaches 150 nanogram per deciliter. But anything more than 150 will tell you that this is because of tumor which secretes the testosterone. So we have to evaluate for that. Okay. So, virilization is not a feature of PCOS. Hirsutism is a feature of PCOS, but if there is a androgen secreting tumor which is leading to PCOS, then we can have virilization features like clitoromegaly, hoarseness of voice, increased muscle mass, temporal balding, and all. Okay, so for hirsutism we have a scoring system, and that scoring system is known as Ferriman Galloway scoring. So it considers the 10 sites where the hair is grown, and the amount of hair grown also matters. So depending upon that we give a scoring. Anything more than 8 is considered to be a feature of hirsutism. So we'll talk about hirsutism in the separate topic, but this is just a feature of the PCOS which we are describing here. Third thing, most of them present with infertility. That could be because of anovulation. Okay, what are the other findings? Obesity, insulin resistance, because of which you can see there is a hyperpigmented patches over the body, like at the neck fold, axilla, groin, and all, acanthosis nigricans, non-alcoholic fatty liver disease, metabolic syndromes. Up to 43% will have metabolic syndrome, and up to 45% will have diabetes mellitus or develop by 40 years of age. And because of the obesity, they can have obstructive sleep apnea and increased risk of coronary artery disease. Okay, these are the clinical features. So how do we diagnose this? So we have a criteria which is Rotterdam's criteria. If 2 out of 3 are met, then we can consider it as PCOS. Confirmation is only when other causes are ruled out. So what are the 3 criteria? One is presence of amenorrhea or oligomenorrhea or menstrual irregularities. Second thing is clinical or biochemical hyperandrogenic features. And third thing is a ultrasound which tells you the presence of more than or equal to 12 follicles which are 2 to 9 mm in size, and ovarian volume more than 10 mm. Now the guidelines have changed. They consider it now more than 20 follicles which are 2 to 9 in size, and ovarian volume more than 10 Okay, so NIH criteria allows clinical diagnosis without imaging. See, any person coming to you with the presence of a menstrual irregularity with hyperandrogenic features, you need not do ultrasound to know the PCOS features. The two criteria itself is telling you that this is PCOS. You need not get an ultrasound done. Also, if there are features of clinical features of hyperandrogenism, there is no need to get a biochemical parameter of increased testosterone to diagnose PCOS. If you want to see if the androgenous excess is because of PCOS or it is because of some tumor, then you can evaluate for that. Okay. The androgen excess PCOS is the same. There is a female with ovulatory dysfunction with polycystic ovaries on ultrasound, but there is no evidence of hyperandrogenism. Okay, what are the differential diagnoses of PCOS? As we have already told, non-classical congenital adrenal hyperplasia, which is a atypical one. So how do we diagnose this? Do value of 17 hydroxyprogesterone level. If it is less than 200 nanogram per deciliter, CAH is unlikely. If it is more than 200, then we have to do something called as ACTH stimulation test. That means you give a 250 microgram of ACTH and measure the 17 hydroxyprogesterone level. If it is more than 1500, the diagnosis is confirmed. If it is less than 1500, we have to think about other causes. Okay. The second is Cushing syndrome. Third is androgen producing tumor, for which we have to measure the serum testosterone level. Anything more than 150 to 200 is considered to be what? A androgen secreting tumor. Okay. So how do we evaluate a woman coming to you with features of PCOS? Need not always evaluate. You have to screen a woman who comes to you with features of PCOS for metabolic syndrome as well, and you can get serum testosterone and all if you want, otherwise it's not mandatory. So serum testosterone or DHEAS, 17 hydroxyprogesterone, not mandatory every time. Other things like lipid profile, serum TSH, fasting blood sugar, postprandial blood sugar, HbA1c, very much important. Prolactin need not be always asked for. FSH LH, to look for the ratio of LH and FSH more than 2:1, and estrogen values will be normal in lean PCOS, increased in obese. Sex hormone binding globulin will be decreased because of hyperinsulinemia and hyperandrogenemia. Transvaginal scanning, which can give you an idea based on the Rotterdam's criteria, which gives a necklace pattern of follicular arrangement. So AMH value is not done routinely, because if you are planning for infertility workup, then you can do it. So once you're diagnosed, to see the cardiovascular risk assessment, check our BMI, waist circumference, again lipid profile and glucose values. For mood disorders like anxiety and depression, and screen for sleep apnea with polysomnography. See, for a general workup, these many investigations are not needed. You can treat a woman based on clinical history as well. Okay. The problem in adolescents is because they usually have these acnes, and physiologically also the cycles are anovulatory, and the PCOS morphology is common in adolescents. So there is a different difficulty in diagnosing PCOS in adolescents. So for that we have international guidelines as well, which gives proper diagnostic criteria. So whenever there is abnormal menstrual pattern which is abnormal for the age and which persists for 1 to 2 years, and clinical or biochemical evidence of hyperandrogenism, hirsutism, more than 10 comedonal acne, elevated testosterone levels. So abnormal menstrual pattern is what? Let's see now. So oligomenorrhea in adolescents, anytime cycle length is more than 60 days within the first 1 year of menarche, or more than 45 days after 1 to 3 years, more than 38 days, more than 3 years post menarche. This criteria is very important. Please note down this. This is very important to diagnose oligomenorrhea in adolescents because it depends upon the age of menarche. It's not the same in the first year, second year, or third year. Okay, it's different every time. And anytime excessive bleeding, more frequent cycle than 21 days, adolescents, or 24 days in adults. Anytime more than 90 days and less than 90 days is abnormal. Okay, so these are the important thing for adolescent diagnosis. Now, what are the differentials? Again, the same thing which we have already told. Now, coming to the management, how do we manage? See, there are three things to be managed here. Not managing the infertility, or just managing the PCOS, and managing the psychological features as well. This PCOS women will also have certain psychological factors in her. She will have depression, she will have anxiety, she will have body shaming, body image issues, and psychosexual issues will be there. Eating disorders will be there because they think they are obese, they avoid eating. So all these things has to be addressed properly. First intervention is lifestyle modification, which is very important. How do we do that? We have to tell them that weight reduction is the main treatment for PCOS. You should encourage them and you motivate them to lose their weight. Okay, exercise for at least 250 minutes per week or more than 150 minutes per week. At least a brisk walk for 30 minutes a day is needed. And dietary changes has to be made. You have to give them a flexible diet chart for them. Along with that, behavioral support has to be there. You have to set a goal to them. If they have any kind of problems, you have to help them in solving. Give them a self monitoring and reviews, something called as SMART goals, which is specific, measurable, achievable, realistic, and timely. You have to intervene in their day to day activity and tell them this has to be done, this has to be stopped. If you're not doing this, then there's no point of us giving any other treatment. This is how you have to tell them strictly. Other non fertility issues, for that we can give drugs for hyperandrogenic features, hirsutism, mechanical laser, and light therapies for hair reduction. And for obesity, we can go for bariatric or metabolic surgery, which is done very rarely. So, drugs were the most first line for hirsutism and irregular cycle is your oral contraceptive pills. It can be used in adolescent also when there is a clear diagnosis of PCOS. As such, no contraindication. Okay, they usually act by, as we know, estrogen and progesterone component they are going to create anovulation in the body but act on the endometrium and try to regularize the cycle. Certain side effects will be there like bloating, headache, abdominal pain, and prolonged use can lead to thromboembolic, but it is very rare. but these risks has to be explained. Okay, and before prescribing OC pills, you have to get a baseline investigations of lipid profile, liver function tests, check your blood pressure, check your sugars. All those things has to be done, and take a proper history of any thromboembolic events before. Okay, secondly, metformin. This is recommended when the BMI is more than or equal to 25 kg per meter square, and this increases the insulin sensitivity. Also, it can be used in type 2 diabetes mellitus. So OCPs and metformin can be given to a woman whose BMI is more than or equal to 30 kg per meter square with features of hirsutism and irregular cycles. Okay, certain other medications like inositol, myoinositol, and dechiroinositol, they basically increase the quality of the oocyte and embryo by optimizing your uh, myoinositol ratio, and they also decrease insulin resistance, alter glucose and lipid metabolism. These are mainly useful when you're planning for ovulation induction or infertility treatment. And certain anti-androgens like letrozole and anastrozole can also be used. And acetylcysteine, it's a newer thing which has certain positive effects. Okay. Other methods are mechanical hair removal either by shaving, laser for the management of hirsutism, and bariatric surgery which improves weight loss, hypertension and diabetes, but there are certain risks associated with itself. How do we manage fertility? Majority conceive spontaneously and only few will need assistance. Okay, we have a three-tier algorithm for the infertility management. First, basic is lifestyle changes, followed by ovulation induction with drugs. And secondly, you can go for laparoscopic ovarian drilling or GnRH agonists. Third, if everything fails, then we go for ART procedures. Okay, this is how we manage PCOS. So, this was a vast topic in a concise manner. Thank you.